Last but certainly not least, we have a very distinguished speaker, Dr. John Morris from Washington University. Dr. Morris is the Harvey A. and Doris May Hacker Freeman Distinguished Professor of Neurology. He's also a professor of pathology and immunology, physical therapy, and occupational therapy. He is the director and PI of the Charles F. and Joanne Knight Alzheimer's Disease Research Center at Washington University. He has been one of the most productive neuroscientists and neurologists in the field. He is also co-authored over 400 peer-reviewed journals, 50 chapter reviews, and 4 books. If I read all the accolades and awards he has won in his tenure, I would take up a long time, but let me just highlight some of them, including the Lifetime Achievement Award from the Alzheimer's Association, the MetLife Foundation Award for Medical Research, and the Potamkin Prize, which is sort of the Nobel Prize of Alzheimer's disease from the American Academy of Neurology. He is ranked in the top 1% of all investigators in the field of neuroscience and behavior. And he also happens to be the chair of our external advisory board for the Alzheimer's Disease Center. So when he talks, we listen. So let's all welcome Dr. Morris.
Thanks very much, Frank. It's a pleasure to be back in Irvine and present at this meeting. It's a real testament to the UCI mind that it's always such a stimulating and very successful meeting. Let me just present my disclosures. Almost all of our funding for research at the Knight Alzheimer's Disease Research Center at Washington University comes from the National Institute on Aging, but we do receive support from a foundation as well as from the Alzheimer Association, and you can see my disclosures there as well. Let me just mention a little bit about this conference, because I think it really is a great gathering and very successful over the years. And it comes because of the great talent at University of California, Irvine. The founding director of of what now is called the Institute for Memory, Impairment, and Neurologic Disorders, Carl Kottman, started the institute in 1995. And then after years of collaborating with another Alzheimer's Disease Research Center, the UC Irvine group was successful in having its own standalone ADRC officially established in 2000, and Carl Kottman was the director. Just 4 years ago, Frank LaFurla succeeded Dr. Kottman as director of the Institute and its ADRC. And it has come to be renowned among the Alzheimer's Disease Center programs for very many accomplishments, but certainly developing unique animal models to explore mechanisms of Alzheimer's disease, issues such as exercise that may help us age without developing Alzheimer's disease, and establishing unique study populations, including one in Down syndrome, and another led by Dr. Kawas of the over 90, the oldest old. And there's another unique aspect of this Alzheimer's Disease Research Center here at UCI. I have not myself experienced this, but I am told that if you are a really strong supporter of the program, Dr. LaFurla will have a dinner that he will prepare himself. So I hope sometime to benefit from that. Here are our faculty and staff at the Knight Alzheimer's Disease Research Center at Washington University in St. Louis. It's a real honor, privilege for me to be able to work with so many truly outstanding and talented individuals. I want to highlight one of my associate directors. This is David Holtzman, who is also chair of the Department of Neurology, and has contributed greatly to the success of our center. But I mention him particularly among all of our other very talented people because together Dave Holtzman and I co-mentored another member of our center, and this is Randy Bateman. And I'll be talking about what Randy has developed throughout my presentation. So I'll begin with sort of setting the stage for the way I consider Alzheimer's disease and how the different terms are used. No one would say that this is the only way to think about it or even the most common way to think about it, but to me, Alzheimer's disease, that term denotes the brain disorder, which, as we know, it causes nerve cell loss. And once that process begins, where nerve cells die, it's a continuous process. It doesn't go through stages of where one stage converts to another. It's simply a continuum. Now, the term Alzheimer's disease, this brain disorder, is there regardless of whether it's sufficient to cause symptoms. So in thinking about Alzheimer's disease this way, we can divide this continuum into two broad stages. One, a pre-symptomatic stage. We term it preclinical to indicate that we cannot detect it, at least presently, by our current techniques. And a symptomatic stage. So a preclinical stage and a symptomatic or a clinical stage. Now, we all deal with patients and families with the symptomatic stage, and we know it to be defined as the process of an individual losing his or her cognitive abilities and losing them to an extent that they no longer can carry out their usual activities. This intra-individual decline. Also, the earliest symptomatic stage, in which many investigators are quite interested, goes by a number of terms: incipient dementia, incipient Alzheimer's disease, prodromal Alzheimer's disease, mild cognitive impairment. But because it's a continuum, it always gets worse. Eventually, it is frank dementia. So a preclinical stage and a symptomatic stage. Now, much of what we deal with in everyday life, as I indicated, is the symptomatic stage. But I'm going to focus today principally on trying to identify the preclinical stage and suggest to you that we need, in both research and therapy, to change the paradigm from focusing only on the symptomatic stage and begin to look at this preclinical stage. So I would say in Alzheimer's disease research, it's the best of times. We have never had such exciting research opportunities and understanding of the illness, and we now can identify this preclinical stage in people during life. Now, we've all heard the term, you don't know for certain whether a person truly has Alzheimer's disease until after they die and come to autopsy and you look at the brain, you see the Alzheimer lesions. Well, now with techniques identifying brain changes called biomarkers, we can identify the pathology of Alzheimer's disease in living people. So we don't have to wait till a person dies to know whether the brain changes are there. So very exciting. Also, we have many very strong therapeutic agents. And some of these therapeutic agents, and I'll try to describe them at the end, may even be candidates to try to prevent the symptomatic phase of Alzheimer's disease. It's tremendously exciting. When I began in the field in 1984, I never would have thought we would be able to even think about prevention of Alzheimer's disease. So the best of times. At the same time, it's the worst of times. Now, this is for two major reasons. One, despite all these promising agents to try to treat the disease, since 2001, every one of them has failed when being tested in clinical trials. It's been very discouraging for the field, for the pharmaceutical industry. All Alzheimer agents that we have high hopes for have shown no clinical benefit. And second, why we stand poised to take advantage of all these research advances, it's ironic that this is the time when there is the least funding opportunities, certainly as provided by the National Institute on Health and its National Institute on Aging. So we can't capitalize on all the very pioneering opportunities that we have at our field. So it's best of times, worst of times. Now here are those drugs that have failed. Beginning in 2001 with the vaccine trial. It certainly worked in mice, but didn't work in men, in part because it was accompanied by a serious side effect. All of the drugs, including the vaccine that I list in this column, treat a molecule that we think it's normal in the brain, but in Alzheimer's disease it becomes dysregulated. Either too much is produced or it's not cleared away properly. And then this molecule called amyloid beta gets out of its normal equilibrium and it's deposited in the brain tissue as the plaque, and that sets off, we think, a cascade of injurious problems that cause brain cells to die. So all of these drugs targeted amyloid, which we think is a key player in Alzheimer's disease. They've all failed. And it's not just been anti-amyloid drugs. There have been drugs looking at other targets, including cholesterol or lipids and inflammation and insulin resistance. And they've all failed as well. So why is this? Well, there are many potential reasons. Hypothetically, I will tell you my reason. And it has to do with this concept of Alzheimer's disease as a continuous process from a pre-symptomatic or preclinical stage moving into the symptomatic stage. So as it turns out, all of those drugs that have failed have been given to individuals who already have Alzheimer's disease dementia. They have the symptoms of Alzheimer's disease, whether it's very mild or moderate. They're in this symptomatic phase. All of the trials that have failed have been in symptomatic Alzheimer's disease. Why could that be a problem? Because we know that by the time symptoms are present, already in certain critical areas of the brain, up to 50% of nerve cells are lost. By the time symptoms occur, when we give treatment, we're treating an irreversibly damaged brain. That's one reason. Second reason, we know in this symptomatic phase of the disease, there are many other pathologies besides amyloid. There's this tau and neurodegeneration, there's inflammation, there's oxidative stress with free radicals, there's vascular insufficiency, many other problems. And we're just trying to treat one of these with the anti-amyloid or any of those other therapies. They're monotherapies. I would propose that if we do develop successful therapies for symptomatic disease, it's going to have to be in this combination attacking these multiple pathologies. So already brain cells are lost, and many other things are going on demanding combination therapy. But now let's expand this treatment opportunity to include this preclinical phase, which I submit is by far the longest period of Alzheimer's disease. The symptomatic phase is the end stage, lasting only 7 to 10 years, where this preclinical phase may last for 20 or so years. Now again, this is hypothetical. We don't know this, but it is possible in this preclinical phase that once the brain pathology starts, at the beginning, it hasn't yet caused neuronal death, neuronal loss, and it may be that one or two key mechanisms trigger the whole event, and if we can treat that one mechanism at that early stage, we can prevent that multiple pathologies. So here, at least theoretically, a monotherapy might work. So this is what we're planning to do is to use our biomarker capability to identify which biomarker becomes abnormal first and try to intervene before they cause so much neuronal loss that symptoms occur and we find ourselves in that conundrum that I developed. So now we're expanding our approach to at least consider treating preclinical Alzheimer's disease. Now, this idea about preclinical Alzheimer's disease has been accepted by the National Institute on Aging and by the Alzheimer Association, developed new criteria published in 2011 describing preclinical Alzheimer's disease, mild cognitive impairment due to Alzheimer's disease, dementia, and all of them suggest that biomarkers may help delineate these different stages of the illness. Now, the molecular biomarkers that look at the pathology of Alzheimer's disease, the disease mechanisms, have to do with amyloid beta, particularly its A-beta 2 isoform, the most malignant of those types of A-beta species. And what we know that in Alzheimer's disease, regardless of whether there are symptoms yet or not, that levels of amyloid beta in the cerebral spinal fluid are reduced. That's a sign that Alzheimer's disease changes are present. We know that in the spinal fluid that tau, or its phosphorylated form in Alzheimer's disease, are increased. And now we have PET imaging ligands or tracers that can tell us whether amyloid deposits are in the brain. The research tool has been something called PIB, but now we're moving into the clinical phase, something called florbetapir. So now we can test individuals regardless of whether they have clinical symptoms and see if they have the brain changes of Alzheimer's disease. We can also look at the consequence of these changes. What happens when amyloid or tau is abnormal in the brain? Well, nerve cells are lost, so we can look for downstream effects of these molecular changes, see if we lose brain volume in critical areas, see if the brain metabolism is disrupted, and so forth. But much interest in these primary molecular pathologies. And I know some of you, many of you perhaps have seen such examples of this, but here is one example of someone undergoing that amyloid imaging, this time with the tracer PIB. And we're looking at two individuals here when a PET scan is sort of slicing the head this way horizontally. And what happens is once we infuse the tracer into the vein, it gets through the blood system, it carries it up to the brain, gets into the brain tissue. If this PIB tracer gets into the brain tissue and doesn't find any amyloid deposits for which it will attach, then it's washed right out of the brain and nothing is retained to give off a signal that the PET scan can detect. So we see a cognitively normal older person here. We're looking for a PET signal in this area of the brain called the cortex. We see nothing. In contrast, here's a person who is demented with Alzheimer's disease. We give them the same tracer, it gets into the brain, but now it sees lots of these amyloid deposits, the plaques, and this tracer is designed to bind to those plaques with very high affinity. It stays there, and it's designed also to give off a signal, a radio signal that the PET scan can detect. So lots of yellow and red in the neocortex means there's lots of amyloid. So we don't have to wait for the autopsy. We can see the amyloid plaque. The plaques themselves are too small to be seen by PET scan, but we can see the fact that the tracer has been bound to the plaques. Now here's another individual. This person has a PET scan that's very similar to the person with Alzheimer's dementia, but this person is cognitively normal. So here's a putatively healthy person with lots of amyloid in the brain. So what does this portend? What does this mean? Well, this is the big question that many research programs are trying to answer. One possibility, there are others, is that this denotes preclinical Alzheimer's, and if this person continues to live and continues to lose sufficient nerve cells, they will become symptomatic. They will develop dementia. In other words, this could identifies someone at very high risk of becoming symptomatic. And in fact, in this particular case, that's what happened. This person 3 years later got a diagnosis of Alzheimer's dementia. Now, we don't know if this applies to everyone, but it's certainly certainly a wonderful opportunity to test, can we find people at very high risk when they're still cognitively normal and try to intervene to prevent the appearance of Alzheimer's dementia. Now, the number of people in the general population, that's a bit of a stretch, the number of people who have been studied in research samples, not necessarily representative of the general population, who are cognitively normal, healthy, mentally healthy people who have amyloid plaques as detected by this PIB scan is surprisingly high. At age 75 or so, it's around 25 to 30%. 25 to 30% of cognitively healthy people have amyloid plaques. It increases as a matter of age. It also is affected by this ApoE factor. But we also can tell that it begins, at least in some people, in middle life, around age 55 or 60. This isn't all that surprising, at least to me, because if there is this long preclinical stage of 20 years or so, it would suggest that as this preclinical stage builds up, that it won't be until, if it begins at 55 or 50, won't be until after 70 that people become symptomatic, and we know that's the case. 93% of people with Alzheimer's dementia are 70 years and older. So I think what we're identifying here is a reservoir of people who, if they continue to live, are very likely to become symptomatic. Now, we just, and others, have recently looked at this preclinical stage of Alzheimer's disease and tried to further subdivide it. And what we are trying to say here is, even within this preclinical stage, there may be different groups. There could be a preclinical stage 1 group in which there's no cognitive impairment, but amyloid is abnormal, but it hasn't yet been accompanied by any indication of neuronal injury. The next stage might be there's abnormal amyloid that does have sufficient damage to cause nerve cell injury, but no cognition changes yet. And then this last stage, they're still considered cognitively normal, but they have abnormal amyloid, abnormal neuronal injury, and maybe subtle cognitive decline. So we've looked at these individuals to see what happens. They all begin as cognitively normal, and we looked at them over a period of 14 years, and it turns out that stage 2 group and that stage 3 group are very high likelihood of becoming symptomatic with Alzheimer's disease because they, again, have the amyloid abnormality, amyloid imaging, in neuronal injury in this group, and not only neuronal injury in this group, but also cognition has already started to decline. So I think we can now begin to estimate risk of becoming symptomatic with Alzheimer's disease in people who have preclinical Alzheimer's disease. Now, this is not germane necessarily to the research findings that I want to emphasize here, but we're going to have to all deal as a field with this idea of amyloid imaging. Right now, it's only for people who have symptoms, and we're trying to determine the likelihood that those symptoms are caused by Alzheimer's disease. And right now, it's not reimbursed by any third-party payer, including Medicare. But as these tracers become available, we're going to have more and more demand for people, from physicians who want to know, well, does my demented person likely have Alzheimer's? And even from people who don't have dementia. But my mother developed Alzheimer's dementia when she was 75, and I'm 70 now, and I want to know what my risk is. Cognitively normal people. So we're going to have to try to deal with this, and as I say, as a field, we're going to have to work through all the different issues. We have other pathologies that we're starting to image. I won't discuss this today. So to date, what I've tried to present to you is there is a preclinical stage of Alzheimer's. It's really substantial. 30% of individuals 75 and older have evidence of preclinical Alzheimer's disease, even though they're cognitively normal. We think these people who have preclinical Alzheimer's disease because they have an abnormal biomarker are at increased risk of becoming symptomatic, as I tried to show you with the different stages of preclinical Alzheimer's disease. But we don't know in an individual person whether this is so. If that 70-year-old man whose mother developed Alzheimer's dementia at 75 came to me and had a PIB scan or a floor-beta scan and it was positive, he would want to ask me as his physician, well, will I become demented? And I don't know that he will. I think he's at higher risk, but I don't know that he'll become demented, nor do I know when he'll become demented. I mean, I could guess. It might be at the age of his mother, but that's a guess. I don't know. So we don't know if everyone defined this way is inevitably going to progress to symptomatic Alzheimer's, nor do we know when that will occur. However, there is a unique and rare group in which we do know both of those factors. And this group is made up of individuals from families where there is a gene mutation that causes Alzheimer's disease. It's a dominant mutation, meaning if you inherit that mutation from your parent, you're going to develop symptomatic Alzheimer's disease. And we know it's going to be at about the time, in general, not always, but about the time your parent became affected. So if you're a mutation carrier, even though you're presently asymptomatic, when you reach your parents' age at which they became affected, you're very likely to become affected at that age, and you're 100% likely to become symptomatic. All mutation carriers develop symptomatic Alzheimer's disease. Now, I mentioned this is a rare group. Less than 1% of all Alzheimer's disease is caused by this autosomal dominant form of Alzheimer's disease. It's very unusual. It's almost always early onset. We say below age 60. Most of these people are 50, 40, 30s, some in their 20s. And you might say, well, why study this group? It's so rare. Does it relate to the far more common late onset Alzheimer's disease? Well, if we look at it, in many ways, this autosomal dominant form is very similar to what we think about in terms of symptomatic Alzheimer's disease. It begins with memory difficulty, it's gradual onset and progression, it interferes with daily function. It is true that in autosomal dominant disease, more people will be affected with motoric complications, Parkinsonism, or they'll have seizures. If we look at MRI, they're the same. They lose volume in hippocampus. If we do amyloid imaging, they have positive retention in the cortex. And also another difference in the autosomal dominant, they also, for reasons yet explained, have retention of this amyloid tracer in the basal ganglia. They have PET, FDG PET changes that are the same. CSF beta is reduced. CSF tau is elevated. So they have many things in common. So we think that if we study this form of rare Alzheimer's disease, it may help us understand late onset Alzheimer's disease. And so that's what we set out to do with a grant from the National Institute on Aging, first awarded in 2008, is set up a dominantly inherited Alzheimer network. This is an international network of academic centers interested in this rare form of Alzheimer's disease. No one center has sufficient number of members from families to make any meaningful conclusions. They're very rare. They're scattered all over the world. Very few families live at in the city where an academic center is. Even if one member is there, their siblings are all over the country. So we thought we would develop a network where everyone would follow the same protocol, and combined we would develop a sample of a sufficient size that we can make some conclusions. And the overall goal is to understand primarily in asymptomatic mutation carriers when the changes of Alzheimer's disease begin in relation to when we think they're going to become symptomatic, and what is the sequence, which one comes abnormal first, what is the rate of change, and we want to compare these individuals to late onset Alzheimer's disease. So we thought we would start off by enrolling a sample of 400 individuals across the world. Now, just to be certain about this, if you have an affected parent and that affected parent has Alzheimer's disease because he or she has a gene mutation, each offspring of that parent has a 50-50 chance of inheriting that mutation. I've already said if that offspring inherits that mutation, they're destined to become symptomatic with Alzheimer's. If they don't inherit that mutation, they're at no more risk than anyone else. It's possible, if an affected dad had 4 children, it's possible all 4 of his children may have inherited the mutation. They're all going to become symptomatic. It's possible none of them inherit the mutation. And then you can't pass it on. It's wiped out for that family. But on average, it's 50-50 on average. So we wanted to enroll 200 mutation carriers and 200 of their siblings, non-carriers, for comparison. Sorry for the complexity of this. The dominantly inherited Alzheimer network is headquartered at Washington University in St. Louis. I'm the principal investigator. We have all of our 8 cores at Washington University and 14 performance sites from the United States, London, the United Kingdom, Australia. We've added additional sites as we've gone along, including 2 in Germany. We're working with other sites as well. Now, I'm going to interject here for just a moment. I thought this was, I'm responsible for this abbreviation DIAN, and I deliberately tried to take a very successful multi-center international study called Alzheimer's Disease Neuroimaging Initiative, or ADNI, and use the same 4 letters, in part because we use ADNI protocols, so we can test our DIAN MRI scans with ADNI MRI scans, comparing early onset and late onset Alzheimer's disease using the same imaging protocols. So I was quite self-satisfied with myself coming up with this term DIAN, but I've already mentioned the funding situation at the NIA is not great. And in 2008, we put our application in, the review panel, and I was really quite nervous about whether we were going to be successful, get the award. And apparently, during this tense time while I was waiting for things, I began talking in my sleep. I started saying things like, "Oh, Diana's so exciting." And Diane is so important to me. And I learned this from my wife, Lucy. So it caused a little problems for a little bit. But we did get the award. We really study these individuals. By the way, all participants in Alzheimer's disease centers are highly committed, highly dedicated. These are tremendously dedicated. They know their family history. They are fully aware. Most of them do not know whether they have the mutation, nor do they want to know. We will provide them funds to go get commercially tested, and they can learn whether they have the mutation or not. We don't tell them our research findings, but we'll pay for them to get commercial testing. 85% of them refuse that, so they don't know. But they certainly know about their family history, and they are willing to go through a very comprehensive battery. We bring them in. Remember, very few of them live in the city, so we fly them in, put them up for 4 or 5 nights, bring in their study partner with them, pay for it all, and they go through full clinical, cognitive, imaging, lumbar puncture, everything that we can think about to try to understand this disease. Here's our enrollment report. I think now we're up to 350. We have 1 more year of funding, easily make our goal of 400. But most importantly, now we're beginning to develop longitudinal data in this very valuable cohort. Here's a little bit about the early entry characteristics of these individuals. We want mostly to study asymptomatic people before the symptoms begin, but to do so, often we have to bring in someone who is already affected, test them, make sure they have the gene to make sure the rest of the family qualifies. Plus, we want some people who are already symptomatic so we can see how well it matches up with late-onset Alzheimer's. Well, so about a quarter, a little more than a quarter of these individuals of DIAN participants are symptomatic. I'm going to just point out here that their average age when they come in of these symptomatic people is about 45 years of age, which is about exactly when their parent developed symptoms as well. So here are the asymptomatic individuals. And I don't know if you can see this, but it's pretty remarkable. It's not 50-50 exactly, but pretty close to 50-50 non-carriers versus mutation carriers. And the parental age of onset for these individuals is 45, 46, 47 years as well. So they're on average 6 to 10 years younger than the parental age of onset. Look at their many mental states, they're both equivalent on that. Highly motivated, the participation, completion rate of all of these procedures is very high. Even for lumbar puncture, it's over 80% in these individuals, and they come back every 3 years and they get it all again. These are the 3 genes that we presently know when mutated cause Alzheimer's disease. In our sample, by far the most common is presenilin 1, almost 3/4. We're beginning to publish data on the DIAN. The most important is a study came out about a year ago in the New England Journal of Medicine. And I'll show you some data on this. There's several caveats to these data. First, they're based only on the baseline or cross-sectional data. We haven't studied these individuals over time, enough of them to comment about that. And second, we don't have individuals at all age ranges, very many people at all different age ranges to make a lot of comments. But here's what I want to try to describe to you. So this vertical line, this dashed line, base 0, is when we expect the individuals to become symptomatic, same age as their parent. And I've shown here some individuals who are non-carriers in blue and the carriers in red. So let's just take a look at mini mental state. So our non-carriers, no matter how much younger they are than when their parent became demented or how much older, always score 30. The asymptomatic mutation carriers, some 10 or 15 years before we expect them to become symptomatic, also score 30. But look, they are declining before, about 5 to 10 years before we expect them to develop symptoms. And the same on their logical memory tests. There's already a decline before symptoms appear. Now let's look at their amyloid deposition is depicted by PIB scan. Again, here's when we expect them to become symptomatic. The non-carriers never accumulate PIB. There's no amyloid deposits in their brain. PIB doesn't attach to anything. The mutation carriers are building up amyloid 15 or so years before symptomatic onset. There's this clear period, many years before symptoms occur. And if we look at CSF amyloid beta here, the mutation non-carriers, no real change in their level. It starts higher, 20 or 25 years for the mutation carriers. That's because these genes all are associated with overproduction of this amyloid beta, but it begins to fall. It's declining 20 or 25 years before we expect symptom onset. So this tells us we have this paradigm. First change, at least as we measure it, is a decreased CSF beta 20 years before symptom onset, followed by this temporal ordering of biomarker changes. So why not treat these individuals? Well, that's what we're going to do. So we formed a clinical trials committee headed by our colleague Randy Bateman. And in 2011, that clinical trials committee morphed into something that we now call the treatment unit. And its mission is to design interventional trials in DIAN participants. Now, it's been a remarkable journey for this trials unit, and I give much credit to Randy and his team. And it's supported not only by this parent DIAN grant that we first were awarded in 2001, we just got some more funding from the National Institutes on Aging and from the Alzheimer's Association, very grateful, but a remarkable group of 10 pharmaceutical companies called the DIAN Pharma Consortium. These companies all provide money, expertise, and most importantly, drugs that the DIAN evaluates to see which ones are best for initial therapy in our DIAN participants. So their pharma companies are collaborating, sharing confidential information with other companies, first time I've ever seen this, to give us candidate drugs that might be best developed for DIAN trials. 10 companies, 15 drugs have been nominated. We look at them to determine which drug is furthest along in the pipeline. Importantly, for anyone who does clinical trials, the further along it is, the more safety data we have. We know how well it will be tolerated by individuals, but also whether the company will allow us to do it. Not all companies necessarily would. Say they had a hot drug that they thought would be important in Alzheimer's disease, they allow us to test it in this very rare cohort, and it doesn't do anything. It's going to scuttle their chances for going forward early. They have a lot of stake in this themselves. So here's what we'd like to do. We'd like to take mutation carriers and give them 3 different drugs. We want a total of 240 mutation carriers going into 3 treatment arms, treatment arm A, treatment arm B, treatment arm C, 3 different drugs. So that means that in each arm, after we go through our randomization process, we think we'd get 40 mutation carriers in each arm, and of them, 30 will get the drug and 10 will get placebo. So it's a 3-to-1 chance of getting the drug. But some will get placebo. Now, I told you that most of DIAN participants don't know their mutation status. So if we only recruit mutation carriers and we say, congratulations, you're eligible for the trial, we've told them you've got the mutation. So we're also going to enroll some non-carriers. There's no reason for us to give non-carriers any of the drugs we're considering because they all target a brain abnormality that they don't have. So it's not going to work, and it's only going to expose them to the side effects. So we ensure, we don't tell them this. Of course, they don't know whether they're a mutation carrier or mutation non-carrier, but we make certain that all non-carriers get placebo. So the first 3 drugs that we've chosen, they're all anti-amyloid drugs. 2 of them are antibodies to the drug. One is made by, the company is Lilly, and it attacks primarily the soluble form of abnormal amyloid beta before it's deposited in the plaque. Another drug has been developed by Roche, gantenerumab, and it targets the anti-amyloid once it's in the plaque. And a third is try to reduce the overproduction of amyloid, an inhibitor drug. And our idea is we'll test 3 drugs simultaneously, and we'll see which one has the best effect on these biomarkers of Alzheimer's disease. The drug that has the best effect on the biomarkers then will go forward for a second leg study, cognitive outcome. The drug that does the best reduction of the biomarker will test for its cognitive success. But here's something with clinical trials. We're going to start with these 3 arms. We found out in June that beta secretase inhibitor is associated with side effects. So we can't follow that Lilly drug. We're evaluating 2 other beta secretase inhibitors, different companies, but we'll see if we can bring that online in time. So we've already started. First time ever that pharma companies collaborate together in a competitive environment to discuss their investigational drugs for a single trial. We've made contracts with Roche and Lilly to do these drugs in a single protocol, and all the contracts were completed in less than a year. The FDA approved this a year ago with no protocol changes. And this is the biggest. Our IRB approved it with no contingencies. And within 3 months from when we announced the 3 drugs that we selected, which is 1 year ago today, the first person was enrolled, December 31st, 2012. And now we have 9 individuals that have come in and have been given randomized to one of the 2 treatment arms. So the first ever trial in autosomal dominant Alzheimer's disease has begun. We have 9 participants. All have been seen at Washington University. Last month, we had an investigators meeting for, I think, 20 other sites throughout U.S. and Canada that we hope to qualify by the end of the year, and then we'll look at international sites to reach our goal of getting 240 individuals into the trial. So prevention trials have begun. We're not the only ones. There are other prevention trials. You may have heard throughout the day the Alzheimer Prevention Initiative wants to look at a DIAN-like family in Colombia, South America. The A4 study wants to look at older adults who are amyloid positive, but it's begun. So we hope that this is going to have a positive outcome. Even if it doesn't, we'll know that likely the amyloid isn't the right target, as we've all thought. We need to broaden our scope, but we will learn something from this trial, and hopefully it will be beneficial. For anyone interested in the DIAN and the DIAN expanded registry, for people interested in volunteering for the trials, there is the information. I appreciate very much everyone's interest, and thank you for inviting me.
Thank you, John. That was amazing. And I just have a quick comment, and I think it's wonderful that we have learned so much about Alzheimer's disease from these mutation carriers that someone is making an effort to give something back to these really special individuals. So that's fantastic. We're running a little bit late, but let's take 1 or 2 questions because we're going to have to tear down this wall so we can open up our Ask the Panel presentation. So we have a question over here on the left-hand side.
I have heard that clinical trials can kill you. That every time you go for a clinical trial, you are actually putting your life on the line. Is that true?
You might not be, John. You might need to use this.
I have heard that driving an automobile can kill you. I don't mean to be facetious. Drugs have risks. Aspirin has risks. No question about it. The question is the risk-benefit ratio. We spend an hour going over all the risks of the drugs for our prospective participants. They can decide whether they want to do it or not. So there's no question any drug has potential risks. I certainly hope your comment that our DIAN trial can kill people is not realized. Was there another? Yeah.
Dr. Morris, I have a question for you. So do you offer patients the option of learning about their mutation or not?
Yes. Yes, we will pay for them to, I think it's $2,000 to take their blood and go to Athena Diagnostics and find out their mutation status. That's available to everyone in DIAN.
And most of them,
85% say, no, I don't want to know.
They take the test but don't want to know.
Right.
We have a question.
Yeah.
Is there any place locally where we can go to find out who has the genetic mutation gene and what are the tests that determine that?
So it's a blood test because the white blood cells, you can test the DNA and see within the DNA in these specific regions whether there is a gene mutation. As I was just saying, it's a commercial test. Cost about $2,000. Your physician, if you have a suggestive pedigree in your family of autosomal dominant inheritance, 50-50 affected people in each
Yeah.
generation over multiple generations,
Got that.
typically early onset, then you can be tested to see if you have it in you or within your family.
Thank you.
But very rare. 99% of people with Alzheimer's disease, even if it runs in their family, don't have these mutations. So this is a rare form of Alzheimer's.
Excellent talk, Dr.
Thanks.
Morris. And I apologize up front if I missed the answer to my question. I was wondering, you mentioned the primary outcome measures for the DIAN study, and you mentioned imaging and CSF biomarkers. I was wondering if neurocognitive data is also included in the primary outcome measures.
So I'm sorry if I didn't say it clearly enough. The first phase of the trial will be on the biomarkers. The drug that works best on the biomarkers then will go to a second cognitive outcome phase. So we will be looking, obviously, at cognition, which is the salient feature of Alzheimer's disease.
Thank you.
Okay, thank you, John. We mandate that anyone considering getting genetic testing first have counseling by a certified genetic counselor. That's part of the DIAN protocol.
Right. And the other point I want to make is that for the first patient in the family, it is expensive, but once you identify the mutation, it's basically a $200 test to confirm the familial mutation.
Okay, thank you all.